Okay, my final prac was at Geraldton, at a community-based outpatient program. It was a multidisciplinary team where we provided assessment and treatment for clients with dementia. And within that, we provided individual and group sessions. So the client that I'm talking about today is Mrs. T. She's a 79-year-old stroke patient. She had a delirium in hospital, and at discharge was still quite highly confused, disorientated, and had reduced memory. She's since been diagnosed with dementia, Alzheimer's. The husband, who is the primary carer, is not willing to accept that diagnosis, and therefore does not accept the progressive nature of dementia, and believes that his wife is going to improve. So Mrs. T's occupations in the past primarily revolved around homemaking, being a mother of 2 children. And things that she enjoyed included gardening, cooking, and going for drives to Northampton and spending time with her husband. She is at the moment completely independent in all of her ADLs. Some of her IADLs she is independent with. However, she also has osteoarthritis. She's at an increased risk of falling. She has reduced strength, reduced coordination in her hands, reduced dexterity, reduced balance as well. And then her cognitive impacts as well increase that risk of falling. So I've used the model of human occupation by Kleinhoffner, 1985, because I feel that the client is quite complex, and I really think that this model once again really teases out the different areas of complexity and really looks at them quite specifically in individual ways. So the client has physical deficits as well as cognitive deficits, which impacts her performance capacity overall. And then plus she has that reduced volition to engage due to her own personal causation, which is the belief that she thinks that she's going to improve, as well as her husband thinking that she's going to improve. So the first question I asked was, how did the multidisciplinary team work together to achieve the goals for Mrs. T? And how do I think that the multidisciplinary team could be enhanced to improve the therapy? Well, essentially what we were providing Mrs. T was physiotherapy and occupational therapy. Her goals were to increase her strength, increase her coordination, increase her balance, reduce her fall risk, and then improve her. And her occupational goals were to improve her activities in the home, her occupational activities. So she wanted to increase gardening. She wanted to increase doing activities like cooking, and also doing the dishes at home. So I guess first of all, there is quite a high amount of evidence that suggests that a multidisciplinary team is quite beneficial for clients with dementia. So some of that evidence is from Smeek, McFate and Haynes in 2011, and it just they suggest that the combined professional skills of each discipline can provides that continuity of care and assists the client in every area to help to increase their goals. So with the physiotherapy, they were looking at mostly reducing the falls risk through exercises, and they provided a home exercise program, and there is good evidence to suggest that a home exercise program reduces falls risk. So things like Smeek, McFate, and Haynes, that was the one that suggests that. The multidisciplinary evidence was Grand, Casper and MacDonald in 2011. So they were the ones that suggest the evidence for multidisciplinary team. And then also the occupational therapy that we were providing was to improve her cognitive strategies and to provide the carer and the client with those cognitive strategies to be able to engage occupationally. And then I guess the physiotherapy combined with the physiotherapy as it's quite functional, led to improving the client's performance capacity in her occupation. So therefore both were working towards her occupational goals. And then the second question, or I guess how the team could have enhanced, would have been by, there is a speech pathologist within the team, and we could have liaised, the professionals could have liaised with the speech pathologist in regards to dementia-friendly communication, things like repetition and keeping commands simple, and then also could have provided those strategies to the client's carer as well to further support him. Then there is also there is no social worker on the team. I think that having a social worker on the team would have allowed the client and the carer to be linked into further support services, and they really would have looked at the fact that the client's been interested in engaging in services that are dementia specific, so they would have looked at other avenues for that. So the next question that I asked myself was, what factors did I identify as barriers to the occupational therapy program, and how did I apply the model of human occupation to overcome these barriers? So the biggest barrier I found was the decreased volition to engage in therapy. So she wasn't willing to come into sessions, and neither was the carer, for information or education around dementia and strategies to improve the cognitive capacity of the client, and to also provide support for them. So they weren't getting the most amount of information to be able to make informed health decisions. So I think this impacted on the occupational therapy program. And I also feel, so I guess that they were quite receptive to therapy in a physical sense. So I guess they were really receptive to things that were helping them with her osteoarthritis, and things that were helping her with reduced balance and coordination. So they were quite receptive to that therapy. So they had some insight that there were impairments. So then within those sessions that were helping to improve her balance and her coordination and reducing her falls risk, I focused more on the physical side of it, and I focused more on reducing her falls risk rather than anything else within the individual sessions. And I also made sure that the sessions were in the home and that I wasn't asking them to come in to the hospital. So I guess that's how I used their dimension of doing and what they were receptive to be able to improve the therapy, and to, I guess, overcome this barrier. And I guess as well, also focused on the osteoarthritis in her hands as well during the therapy, and looked at modifying utensils, and there was evidence for modified utensils to reduce pain and also increase occupational engagement. And that evidence would be from Clark, Avery Smith, Wald, Anthony and Holm in 2007. And then the other, with those barriers, I guess, was the osteoarthritis. That would have also been a barrier, which would have reduced her performance capacity. But once again, they saw that and they had insight into that, and so therefore were willing to be receptive, to have therapy with that. But then the other thing would have been her reduced memory for the different, being able to remember the different strategies that I provided. So within that, I made sure that the therapy was in the home to increase transferability and also familiarity within the dimension of doing, and also made sure that the client's carer was involved as much as possible in the therapy sessions, as he would have been able to remember the strategies better than she would have. So that evidence comes from Wolf 2011. And then my last question was how the practice context impacted on the OT program. It mostly benefited, I found, the practice context, mainly because it was a multidisciplinary approach and we combined OT and physiotherapy in the one session, which made the effective use of their time to work towards their goals. It was community based, so it meant that the client never had to come into the hospital, which they did not want to do in the first place. So it was therefore the therapy was more meaningful to them, and increased transferability and also increased compliance to the therapy. Um, I have discharged the client from the service, but we provide them with the most amount of information at discharge, and we say, look, if you need any more assistance, if you need further assistance, we are available. So we don't close the doors completely. We still allow them to be re-referred, which is, I think, really good, and they know that that's there if they need assistance. Some of the negative impacts, I think, on the OT program were the time constraints of the therapists, and also we have a limited car pool to go out. So it means that we only have 1 hour weekly sessions with the client, which means that we're relying a lot on the compliance of the client to engage in therapy at the home. And I guess the other thing as well, because I'm a student therapist, I think that impacts as well in two ways. One's positive in the sense that, you know, I'm providing recent up-to-date information to the client, but in the other sense, I don't have the same experiences as a lot of the other therapists at the service would have, and therefore might not meet some of the client's needs. And that was the end of my final session. Thank you, or my final placement. Thank you. Bye.